some more people to join in. I'm going to be recording this meeting. I hope everyone can hear me well. I'm just going to share my screen, a PowerPoint presentation right now. This PowerPoint presentation is basically just going to take you through a few questions that a lot of people have asked about the Indian Hernia Collaborative. What is it? How are you going to benefit from it? Whether any ethics committee clearance is required, consent, this, that, all of it. We're just going to go through it in brief. And of course, if any of you have any questions, feel free to reach out to us individually as well. So the Indian Hernia Collaborative is going to be a prospective, multi-centric data collection. This is going to be for ventral and inguinal hernia patients. The data collection is obviously going to be prospective, and this is going to be an observational data collection, or let's call it an audit. So as such, no practice outcomes are going to be changed because of this data collection. So the aim is to have registry-like data set in our hands to allow us to streamline the data set into multiple studies and publications along the way. This will also help us to answer specific research questions or scientific questions that we have using that data set. Obviously, creating a registry is a big challenge in a country like India because there's such a heterogeneity in terms of softwares used and platforms used in public and private hospitals across the country. So that is something that obviously is the final aim, but it is not something that is feasible at the moment, which is why the Indian Hernia Collaborative has come into birth. So what is it? What is in it for you? You will be part of one of the first initiatives in South Asia to gather data and analyze practice patterns amongst Indian surgeons. We will also be recording post-operative follow-ups and post-operative complications, post-operative patient outcomes, which will also help us understand a lot about ventral and inguinal hernia repairs amongst Indian patients, as opposed to most of the data which is out there, which is more Western based. Additionally, all these studies will follow a collaborative authorship model, which allows collaborators to be a part of the author group. Now, this is a question that most people have had, and that is, do you need ethical clearance to enter the data? So as per our understanding and clearing it with our local ethics committee, the study is an audit which won't require ethical clearance as such. This is registered with the ICMR and the CTRI number is there. We'll be sharing the CTRI number in a 2-page document with you very shortly, which will allow you to send it to your local ethics committee if you need any clearance. It's best to check with your local ethics committee, obviously, if you need any clearances before commencing data entry. And once this meeting is over, I'll be sharing either via email or WhatsApp with all participants a 2-page document to facilitate the clearance if needed. What about consent? So a similar study was performed by the IAGES year before last, which was recently published by Dr. Beg et al. In this, the routine consent forms just had a single line that was added. Again, we'll be sharing this line with you via email, WhatsApp, and all of that. This can be just added to your consent forms. And the line is, I consent to share my data in a confidential and anonymous way for academic purposes. Now, before we jump into the Excel sheets and talk about that, I'm just going to run through some basic guidelines for data entry. We want to try and avoid copy pasting on the Excel sheet as far as possible because the Excel sheet is coded in a particular way. So if you enter data as is, the coding will remain intact. The Excel sheet is coded with mostly drop-down menus, which will allow easy data entry. Only a few columns have free text entry. Please adhere to this format. If there is a free text entry, please try and limit the number of words you enter, because the more the longer the entry is, the more difficult it is for us to analyze and understand it. For mesh brand names or for tacker brand names, etc., just try and enter these exactly as it is on the manufacturer's box. This will make it standardized and will allow us to analyze the data easily. There will be subsheets at the bottom of every Excel sheet, which will give you information such as classifications, instructions, etc. before entering the data. Please make sure that you do not enter the units of measurement such as centimeters or millimeters or minutes while entering this data, as that is going to create a lot of trouble for us to analyze the data eventually. I'm just going to now share the Excel sheet for the ventral hernia data entries. I hope everyone can see it. And I'm just going to quickly go through this Excel sheet so that we can now, so that most people have an idea as to how to enter data on these Excel sheets. So the center details need to be filled only initially. The center, city, surgeon, the highest degree of the primary surgeon, year of finishing surgical training, all this has to be filled only once for each center. Following that, obviously, demographic data we'll be taking. Name and phone number can be removed before submission. Once you're submitting it, we won't have any identifying data for any of the patients, but it's important to record name and phone numbers for your personal use, because once you enter this, only then will you be able to follow up with the patient in future. Age, gender, etc. As you can see, there are drop-down menus for most of the things, whether it's irreducible, reducible, or sliding. Smoking, diabetes, COPD, BPH, coronary artery disease, CLD, CKD, all these are drop downs, which are yes or no. History of large, so urethral stricture, bladder neck obstruction, etc. Hypertension, other comorbidities, whether the patient is constipated or not. The BMI is something that we want to record for most patients. So this is an interesting, sorry.
Harsh,
Yeah.
that Excel sheet is not visible. Your presentation is on.
Oh, okay. Just a second. Just a second, please. Sorry.
Yeah. Now it's there.
We can see it?
Yeah.
Okay, perfect. It's visible, right?
Right. Now it's there.
Okay, perfect. Sorry. So I'll start from the beginning again. Center details to be filled in only once for every center. Demographic details like name, phone number, etc. Age is to be entered in years. Please enter the age as, say, 18 years, but don't write years at the end of it. Makes it easier to analyze. Gender, smoking, diabetes, hypertension, etc. Now, ventral hernia working group classification, we've kept subsheets at the bottom, if you can see out here. So if at all you have any queries regarding how to classify this, all you need to do is go to the subsheet. There's grade 1, grade 2, grade 3. You figure out which group it fits in, and you can go back to the sheet and enter it as per the drop-down. Most of these are all drop-downs. Now, number of previous hernia surgeries is a manual entry, say 3. So if you have 3 hernia surgeries in the past, we've kept the mesh positions of each surgery as a drop-down in 3 separate columns. So please enter it as required. Additional hernia surgeries, this is a free text if patients have undergone more than 3 surgeries. Any history of previous abdominal surgeries, we've also recorded the location of previous scars. We've tried to incorporate all, but if you feel it doesn't fit into any, others is always an option. Other comorbidities, there's also an option to enter free text if it doesn't figure in the dropdown. This is the dropdown. So free text can be entered every time you don't have an option for the dropdown. Now, in terms of procedure, date of surgery, all these dates will be entered in DDMM Y format. So it'll be 15/9/2022 if it is done tomorrow, and it will get automatically recorded. If you record it in any other way, it will not be recorded. So please adhere to that. Type of anesthesia, nature of surgery, all these are drop downs. We've tried to incorporate all surgeries in a drop down, but if you feel they don't fit into any of these, please click on others and enter free text as appropriate. Same with MAS. If it doesn't fit into any of these, click on others and enter a free text as is appropriate. Now the defect size, both the transverse and longitudinal, how to record it, has been written in the definition and instructions. We want to standardize this. So during the MAS procedures, um, we want you to reduce the IAP to 8 millimeters of mercury and then measure the defect size internally using 2 needles at each edge. Now, if that is not possible, I understand that some people may forget it, may not be able to do it. The defect size can be used, the entry can be made using the CT defect size measurements as well, as those can also, those are also fairly accurate. The number of defects, this is something that we want to record, the EHS site and the EHS width of each hernia. This has also been recorded on subsheet 3. If you can see, this subsheet will give you all the information about what are the different classifications for incisional hernias. Mind you, this will only be for incisional hernias. So it will let you know what is M1, M2, M3, M4, M5. If it is a lumbar hernia, L1 to L4. How to record the defect? It needs to be from the cranial most part of the cranial most defect to the caudal most part of the caudal most defect. If there are multiple hernia defects, that has been very well captured in this illustration out here. In terms of width, there's W1, W2, and W3. So we've recorded these also as a dropdown. So please select it as required. If there's divarication, again for divarication, we've kept the EHS classification of divarication as a subsheet 4, which you can use to record the data. The intraoperative details, the operative time in minutes, try and record it in minutes, not in hours, so we standardize it. The mesh length, mesh width in centimeters, the brand name, try and enter it as per what is written on the box. The pore size, whether it's microporous or macroporous, again, it's a drop down. The mesh type, here again, we've kept a drop down. If it doesn't fit into any of these, others is always an option, and you can enter free text. The mesh location, type of fixation, we've added all the different types of fixations that people use. If you've not used fixation, you can always click on no fixation. Tackers, type of tackers, number of tacks, all of this, the technique of suturing, whether it's intracorporeal, transfacial, the type of suture used, whether drain's been used for the up over the mesh, whether there's a subacute drain or not. Any concomitant surgeries, the nature of concomitant surgeries can be entered. If it doesn't, if it's not any of either the lap chole or total abdominal hysterectomy, you can always select others and enter the nature of concomitant surgery. Antibiotic prophylaxis, whether you use it or not, and if it's a single dose, 3 doses, more than 3 doses, whether there was a conversion to open surgery, analgesia, any of these combinations as per what has been specified, and if any adjuncts have been used, such as epidural or Taplock. So this is pretty much it as to what you will record when the patient comes to you and when the patient is operated. Everything beyond this is post-operative outcomes. So the post-operative day 1 pain score will be as per the visual analog score, the VAS, which is 0 to 10. That everyone's well versed with it and familiar with it. The time to mesh drain removal, subacute drain removal, all this will be recorded in days, not months or years, but in days. The number of days antibiotics was continued. We've kept this as a drop down to avoid any random entries. The Clavian-Dindo score, again, you can refer to sheet 5 for the Clavian-Dindo score. There's grade 1 to grade 5 if there was any complication. And in case there was no complication, please enter it as 0. If there was a death, any major medical complications, surgical site infections, whether any mesh explantation was required, a hematoma, seroma, whether there was a recurrence or not, any fistula, sinuses. As you know, we do get a lot of these because of atypical mycobacterial infections. Any 90-day readmission, that's an important criteria. Pain, which is lasting after 3 months, what is the visual analog score, and the time to recurrence. Now, outcomes at 6 months, we'll be recording it before 6 months, so it will be at your 3-month visit. Following that at 6 months, so we'll be recording SSIs, mesh explantation, hematoma, seroma, recurrence, fistulas or sinuses, pain, what is the pain score and time to recurrence. pretty much this will be the same that we'll be recording at 6 months, at 1 year, at 2 years, at 3 years, 5 years, and then eventually at 10 years. Now, there's an additional thing that we've added to this particular Excel sheet. This is absolutely optional. You don't need to record this data if you don't want to, but a lot of people were asking to add this to the Excel sheet so that they can record their own data. And that is CT characteristics or CT findings when performed. So whether a CT scan was performed, transverse size of the defect, longitudinal, what are the contents, the hernia sac volume, abdominal cavity volume, volume ratio, whether there was a diastasis, the muscle width, right rectus, left rectus, the lateral muscles, all of that has been taken from a recent publication that was published by Dr. Jignesh Gandhi in the, I think, Journal of Minimal Access Surgery. So this is something that you can use, but it is not absolutely mandatory. I'll be putting an optional next to this so that people know that it is optional. So that's pretty much it for the ventral hernia data sheet. Just open the inguinal hernia data sheet. Okay. Can everyone see the Excel sheet?
Yes, we are able to see.
Okay. All right. So again, everything is similar to the ventral hernia Excel sheet in terms of demographics, in terms of patient characteristics. There are a few extra things that we've added, such as, sorry, I'm just going to mute everyone.
પછી એવું લાગે છે કે એન્ડોસ્કોપી કરીને ખોરાક જે આમ ખાતા હોય ને એ અટકતો
request everyone to please mute themselves.
Dr. Harsh, if you have started the meeting, you can mute people.
Yeah, I did. I just. Okay. All right. So there are a couple of additional things that we want to record for the inguinal hernia data sheet. One is a history of urinary complaints. The other is constipation, because these two are more important when it comes to inguinal hernia. The BMI, number of previous hernia surgeries, again, similar as previously. Okay, now in terms of procedure, we're recording the date of surgery in a similar manner. The type of anesthesia, nature of surgery, and method of sterilization of laparoscopic instruments, whether autoclave, ET, or plasma sterilizer, Cyrex, or formalin was used. Out here, we've split everything into right and left. So if there are people who are operating only a right inguinal hernia, for instance, keep the left side blank. People who are operating a bilateral can enter data in both, because I understand that some people may be doing two different procedures for both different sides. So we've kept it separately. Intraoperative details of the hernia, whether it's unilateral, bilateral, whether it's a direct, indirect, femoral, pantaloon, sliding, all of that will be recorded, whether it's on the right side or left side. The EHS intraoperative width, whether it's 1, 2, 3, X means it's not being measured. Now, again, we've kept the classification as subsheet 2. So you can use this classification to, if you're not sure about where your hernia fits in. In terms of intraoperative details, the operative time, again, please write it in minutes. What type of mesh has been used? It's whether a mesh has been used or no, firstly. The mesh width and length in centimeters, what's the pore size, mesh type of mesh material, all of that. If you can see, flat 3D self-fixating is again something which is more specific to inguinal hernias as compared to ventral, whether it's a polypropylene or polyester mesh. What are the port positions in a TEB, whether they're midline or lateral, mesh fixation, type of tacker, number of tackers, if used, and number of sutures. If it's a tap, method of peritoneal closure, whether it's suture, tacker, glue, if the sac was plicated, whether drain was placed, and whether a separate scrotal incision was taken or not. Now, the same thing is going to be recorded for the left side. I know it looks pretty overwhelming, but when you try to enter it, it's hardly a 5 or 10-minute job immediately after your procedure. Now, there are a few other things that we are going to record intraoperatively, whether concomitant surgery has been done. Now, out here, we've added TURP as one of the concomitant surgeries because we know people do operate a lot of TURPs along with lapping guinals. If an umbilical hernia was added, a hydrocele was added, any other concomitant surgery was done. Antibiotic prophylaxis, conversion to open surgery, analgesia, adjunct analgesia is the same as what it was with the ventral hernias. Now, these are the postoperative outcomes. So we are trying to compare pre-op and post-op pain scores. So before the surgery and at post-op day 1, time from the date of surgery to the date of discharge, whether there was any death, major medical complications, all of this is the same as the ventral hernia. Now, the surgical site outcomes that we are trying to record, this is at 30 days. The Clavien Dindo grade, SSI out here, we've classified it as per this into a superficial, deep, and organ space SSI. If you don't know where your surgical site infection fits in, just go through this, you'll be able to figure it out. It's pretty self-explanatory. So superficial, deep organ space is as a drop-down. Any mesh explantation, hematoma. Out here, what we've tried and done is if suppose there's a hematoma, we want to record the side of the hematoma, whether it was right or left or bilateral. So we've kept an additional column for that. A seroma, if there was a seroma, what was the management performed for the seroma? If it was managed conservatively, how many days to resolution of the seroma? Groin pain is something that we really want to assess, whether any patients had groin pain, what was the side of the groin pain. If they did have groin pain, how to classify it. So again, we've recorded the classification of groin pain out here. If you can see mild, moderate, and severe, that's been recorded in subsheet 5. So you can just switch over as and when required. We are also trying to record the VAS scores for groin pain, both on the right and left side, if at all they're on both sides. If there was a recurrence, whether it was clinical or radiological, we want to record that. And that's pretty much it. Now, here we'll be recording outcomes at 30 days, followed by 90 days. Then at 1 year, that's 12 months. Then at 2 years, at 3 years, at 5 years, and at 10 years. So the follow-ups are pretty much going to be the same as the ventral hernia. And the data entry is also pretty much going to be the same. It's just that the Excel sheet seems larger because there's both right and left. So yeah, that's about it. All right. So if anyone has any questions, I think there's one question that Dr. Ashok has asked. What is the period of data collection? We'll be recording data from the 15th of September 2022 onwards. That's from tomorrow onwards. From tomorrow up to 6 months, we'll be assessing how things go forward. We'll be having a review meeting 6 months down the line, and then figuring out how long ahead do we want to record data. We can keep this very fluid in the sense we can have data recorded up to 1 year. Following that, we can get that data, analyze it, and publish something, but continue recording data up to 2 years or 3 years or even 5 years. So this is an ongoing, continuous data record. It's not going to be there only for a few days or a few months. The minimum number of patients for a surgeon, we've not defined that yet. We can define it as and when required. A protocol will be sent. This will not be a protocol per se. It will basically be a 2-page document describing the study with the aims, what is the methodology of the study, and why a consent will not be required will be noted down. Why a specific consent will not be required for the study will be recorded in that 2-pager, and that can be forwarded to your ethics committee if required. All right. I think, Dr. Sarfaraz, if there's anything that you would like to add, if there's anything I'm missing.
We can't hear you. Can anyone else?
Uh, I'm Pallavi, I can't hear Dr. Sarfaraz. Can you hear him?
Doesn't matter whether you're getting the clearance or not. I think, first of all, that is it's just a prospective audit, and it's not influencing your practice in any manner. But even then, we have got a CTRI number from ICMR. You may still require, despite all of this explanation, you may still require local ethical clearance. So even if that is there uppermost in your mind, I am requesting you start collecting data. It doesn't matter about whether your local ethical clearance comes later or not. That's number one. And number two, do keep data about your patient with the name and phone numbers with you. Let's say about 3 years later, we thought that we would do a patient reported outcomes, look at their quality of life. And it's just a phone call on which they are supposed to give their responses, or a link has to be sent to their phone numbers. Then at least your data will help in doing this study on patient reported outcomes. PRO are becoming a very important indicator of outcomes for any surgery. And most of the world is shifting from surgeon reported outcomes to patient reported outcomes. So it's important that you keep name and phone number. So these are two things that came into my mind. If there is any other question or any other suggestion from anyone, I think it's a good time to talk. Okay. Do we have anything in the chat box?
I think Mandar's asked a question last time. Inguinal hernia duration was set at maximum 1,000 days. I think we've kept the data recording up to 10 years, which is more than 1,000 days. And that is what we are looking at as of right now. I would also like to add, I think what I have not said when we were presenting the Excel sheet is that this Excel sheet can be used by you for your own practice as well, whether or not this study is a part of your plans or not. If you're planning to be a part of the study, that's great, but you can also use this data sheet to record your own data and keep that data for future publications from your end or as a collaboration.
Yeah.
So Harsh, my query here was that when you entered the data in patients verbatim, how many years is he having this problem since? So I think the number of days set were about 1,000. I don't think we have an option of a patient coming with 7, 8, 10 years of duration of hernia. So
Right.
is there a limit set to that particular data, or how can we rectify that?
I have set a limit to the maximum number of days is 1,000, but I can remove that limit if that's
Yeah,
a
because people do come with hernias of 7-10 years duration, so it becomes difficult to fit into those 1,000 days criteria sometimes.
I understand. So I'll remove that limit that I
That
just.
was the concern we found last time around when we were trying to enter data for the previous trial thing that we were doing last time.
Yes, yes, perfect.
Thanks.
So I think Dr. Ashok has a question. Sir, if you could
Yeah.
go ahead.
Yeah, I just wanted to ask you, we have got a CTRI number, you said. So do we still require consent from the patient? Because in our hospital, they insist that we take an ethical clearance, and research committee board requires that we take a consent from the patient.
So, Dr. Harsh, do you think it will be different for an audit and prospective data analysis? For the audit of your own data, do you need an ethical clearance?
So yeah, I mean, for an audit of your own data, I don't think an ethical clearance is required. If it's a prospective observational study, if you put it in that way, yes, you may need an ethical clearance, but this is more of an audit of your own data, where individual surgeons are collecting data and then collaborating and using that data for publication. In terms of consent, you can just add one particular line, which we'll be sharing with you all, that Dr. Beg and I had discussed, which was the same thing that was done for the previous study with IAGES that Dr. Beg was involved with. And I think if we add that one line stating that patients are willing to record giving permission for you to record the data for academic purposes, I don't think it should be a problem. In terms of ethical committee clearance, I think Dr. Ashok, you had those concerns. You had messaged me as well. I'll be sharing that 2-pager with you, and you can forward it to your ethics committee, and we can help you with any documentation you require in terms of CTRI number or whatever.
Yeah,
Okay,
I just
thank you
like
so
to
much.
add that like to add one line when you are making your consent, just one line saying that I give consent to my anonymized data being utilized for research purposes. That is sufficient from the patient's point of view. You are covered. So
that
that
line is
something-
already there in our consent. That line is
Yeah.
already there in our
Yes,
consent.
so most
routine
consents
consent
have
form. Yeah, because ours is an
Then it's fine.
ours is NABH accredited. So we have that line already included in the consent form.
Correct. So absolutely all right then. Dr. Aditya Bakshi has something to say.
But in spite of that, ethical committee, they insist on clearance from the ethical committee before any study, before any publication, and they expect us to go through research also. So,
And Dr. Ashok, we know that we have done this earlier also. We have discussed this with you. It's a little sad that we do not have these things in proper place from the ICMR. But sooner or later, I think that has to change. As of now, we will just go on with what we have to do. And that is, if you think local ethical clearance is required, give them the CTRI number, give them the consent that you are involved with, and tell them that it is not going to change your practice. That should be enough to get your local ethical clearance. Yeah.
Thank
Hi.
you.
So my question is, we have to define the visual analog scale that we are going to be using. So is it 0 to 10, 1 to 10, 0 to 100?
Harsh, you're muted.
I think that's a valid question. I can add it as a subsheet in both the sheets. I'll add it as a subsheet and share it.
Make it 1 to 10. I think most people would use as 1 to 10.
Right.
Most papers also use 1 to 10.
I'll just add it as a subsheet. I think that's a valid point. People may get confused. There are different scales. So we'll just add it to the subsheet so people can refer to that and use it.
Or do you want to drop down as 1 to 10?
I can do that as well. Yes. Sounds good. Perfect.
Okay.
I think Dr. Jyotsna had a question. Is ethical committee clearance a must? I think we've already answered that.
We discussed that, yeah.
But if you feel it's required at your end, please do it.
Pinky has a question. Pinky, go on. Unmute yourself.
I was just complimenting Harsh that excellent excellent sheet and excellent work. This is too much of hard work.
Yeah, Pinky, you and I know that this all requires hard work, and people like Harsh have to do it.
Yeah, it's Harsh, it's too good. Very nice.
It's
Yeah,
it's
he's
all
done an excellent job.
it's all after long phone call discussions with Sarfaraz sir and going through it. I think maybe a few times in the last month.
Yeah, but it's too much. And the statement that even if you people don't want to join the study, use the sheet, that was very nice. That was a very nice statement.
Yeah. Dr. Manoj, please unmute yourself, Dr. Manoj.
Yeah, can you hear
Yeah.
me?
Yes, we can hear.
Yes, we can hear you.
Okay, now the thing is that I already downloaded the Excel sheet, and there was one message from Sarfaraz which said that you input your data from the 1st of September. So I'd already started inputting data from 1st of September into the Excel sheet, but that Excel sheet had some problems with the drop down menus. Fortunately, I mean, I could use the data and validation this thing and remove that the restrictions that were there on the date column. Now in future, if the Excel sheet changes, and I've already inputted like say 10-12 cases of data from the 1st to the 15th. Now, and if I download the new Excel sheet, will I have to download the new Excel sheet? And if I download the new Excel sheet, will the data remain, or I'll have to re-input all that data?
No, Dr. Manoj, let me answer that question. Along with you, there were some others also who wanted to know, can we use the Excel sheet? And I thought it is a good idea to let people start using the Excel sheet so that they become conversant with it. And that will make them very quick. When you have done it for, let's say, 5 to 10 times, that's the learning curve, I think. And then you are already on it. You are quickly able to, enter the data. Now, as far as research and data collaboration is concerned, we start from tomorrow. And then what you do is that those 15 days, you can keep it for your own purpose. But as far as this data collaboration is concerned, download the fresh Excel sheet after the deliberations today. There may have been a couple of changes as per the suggestions by the participants here. So you download the fresh one and use it from tomorrow. So don't worry about what happened in the last 15 days. Those are your good data. You keep it for yourself, but don't use it for this data collaboration. For this purpose, the data collaboration starts officially from tomorrow, 15th of September.
Okay.
Don't consider what you did early as a waste. You actually gained a lot by doing this, repetitively. I think it's a good exercise, and not only for you, so plenty of people. We've been doing the same thing.
But Sarfaraz, it's a good idea. What can I do one thing? Or the patient operated from the 1st to the 15th. Can I just put them as operated on 15th?
No, we didn't hear that. We didn't hear that.
Okay, so
right.
I need to download the new sheet and enter the data from the 15th. Now, what happens in the future? Supposing in the future also some changes are made to the Excel sheet and we need to upgrade that Excel sheet, will we have to, if we download a new Excel sheet, will the data remain or will the data go away? And is there an option where, when you make a sheet that to keep the...
No, I got your question. Harsh can answer that. We have a plan. I think Harsh about the app and everything and how we can upgrade that. So Harsh, if you can share your thoughts, unmute yourself, Harsh.
Right. So, sir, it's a very simple thing that the Excel sheet that you're entering data on, if by any chance there are any minor changes that do occur in future, that Excel sheet remains as is. Future data will be entered on the new Excel sheet. That future data that you're entering on the new Excel sheet and the old data on the old Excel sheet can remain separate, but will be combined eventually, which I can do. Even if there are additional columns, I'll make sure that the data has not been missed. Secondly, we are trying to work on something that makes it easier for people to enter data in the form of a web-based app. Now, that's something that's not very easy to do because, I don't know how to code. I don't know HTML or any of these coding languages, but we are trying to get some external person to help us create that web-based app. In case that happens, then we'll be switching over from the Excel sheet to the web-based app, which will eventually give us an output as an Excel sheet. The control of the web-based app and the data will be in the hands of the surgeon who is entering the data, and that surgeon will then share it with us for final data collaboration.
Yeah, but I'm sure it should be possible, even if you make a new Excel sheet, it should be possible for me to move my data from one Excel sheet to the other, right? To the updated one.
So it is absolutely possible. The only thing is if there are new columns or new entries that are being made, if you just copy paste it, it may not go column wise. Then the data may not enter exact as is. So it is better for you to then use two separate Excel sheets, and then I will amalgamate it for you.
Okay, thank you. You'll do the dirty work for us. That's good. That's good. Thank you, Harsh. It was very good effort.
Finally, I think anybody who wants to, who stumbles or has a problem in recording data or wants us to demonstrate one entering of your case, we can always do that. We are a phone call away. Many of us out here who are ready to help you. I'm there, Harsh is there, Pallavi is there, Dr. Hema has agreed to help us in this. And I'm sure there are many more who would be helping us in this. So feel free, if you have any problem in entering your data for the first few cases and you are not able to understand, then just give us a call and we will help you out.
All right. I think we've pretty much achieved what we had to. I'll get to work, get everything in place, and I will send everything on the WhatsApp group. There's another request from everyone who's attending here. I'll also put it on the WhatsApp group. I made a very short Google form. Request everyone who's interested in the study to enter their email address and other details on the Google form so we have your data. So if we need it in future, it is easy for us to communicate with you.
Yeah. I think you need to put in the Excel sheet in the group A, the updated one.
Yes.
After this meeting and the recording of this meeting, and we impress on people that tomorrow we start collecting data. Yeah.
I'll also be sharing the Google form and the 2-page document for all those who require local ethics clearance.
Yeah. Perfect. Great, Harshu.
Right.
You've done a hard job. Thank you very much.
Thank you, sir. It's all your effort, and I've been
No. Please. Okay. Thank you very much.
Thank you. Thank you all.
I
Thank
think
you.
we'll end.
Good
Thank
night.
you.